Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a sports and shoulder surgeon at Wake Forest in North Carolina. Brian, how are you?
Hey, I'm doing great, Peter. How about you?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeon Society, University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, today we have an episode on a hot topic of shoulder surgery, which is whether there is a future for the anatomic shoulder arthroplasty or whether we are currently witnessing the slow death of the anatomic. Now, to discuss, we've invited several nationally renowned experts. First, from the Paley Orthopedic and Spine Institute in Palm Beach, Florida, we have Dr. John Levy. John, welcome to the podcast.
Hey, thanks for inviting me.
So next, from Sierra Pacific Orthopedics in Fresno, California, we have Dr. Julia Lee. Julia, welcome to the podcast.
Thank you guys for having me. It's an honor to be here.
And finally, from the Florida Orthopedic Institute in Tampa, we have Dr. Mark Frankle. Mark, welcome to the podcast.
Thanks, Brian. Thanks, Peter. Great to have Julie and John to discuss this interesting topic.
Okay, so let's start with the most important issue. I want to have each of you answer the question, are you still performing anatomic arthroplasties in your practice, or have any of you said enough is enough? Mark, start us off.
Yeah, I still think anatomic arthroplasty is an excellent operation. So I still perform it on osteoarthritis with intact cuffs. But I'd say the number of anatomics I do with intact cuff now is probably less than I did 10 years ago, or maybe 15 years ago. So there's definitely been a shift in me utilizing reverse arthroplasty a bit more than I had historically many years ago.
Julia, what about you?
And I would certainly agree. I don't have the same amount of experience as Dr. Frankle does, but I would say that I still do anatomic shoulder arthroplasties. But over the past couple of years, my threshold from going from an anatomic replacement to a reverse replacement, not in a revision setting, but just choosing that as a primary implant, the threshold is lower and lower to put a reverse in instead of an anatomic. But yes, I still do think that the anatomic is a great replacement. It's a great surgery. And I still believe in it, although my ability to jump or my preference to jump or reverse is becoming lower and lower.
What about you, John? Are you on the same page?
Yeah, I mean, I'm still a very strong believer in the anatomic shoulder replacement. I think that I believe my best results of all arthroplasty sit in the group of patients who I've been able to do an anatomic on. I have been doing, I still do reverse for patients with osteoarthritis, and I think it's really, it's evolved, and I think in the correct patient population, a reverse does better. But in the majority of osteoarthritis with balanced shoulders that with reasonably good function, you put an anatomic in and they're doing everything they need. Their chance of getting to normal is way higher than if they had a reverse shoulder arthroplasty. So I'm a huge believer in anatomic shoulder. I think that we are biased by old data on old implants, and as we start to understand what's going to happen as we see the more modern implants of anatomic shoulders, we're going to see this a resurgence in anatomics. I'm convinced.
So we have a very unique thing here. We have consensus. Obviously, all three of you have demonstrated an enthusiasm for the anatomic. You've talked about your lowering threshold for the reverse. Mark kind of preempted a little bit with some of his answers, but John, how has your practice changed in terms of anatomic reverse versus reverse in the past 5 years?
I don't even know if it's in the last 5 years. I mean, we look back at our data, and I've been doing the same amount of cuff intact reverses since 2014. So my practice hasn't really changed. I think what we are starting to understand is who are the patients that don't do well with anatomics. Mm-hmm. I don't think it's a blanket statement that over the age of blank you should do a reverse. I think that's wrong. I think there are criteria that I look for, and I would say patients with reasonably good passive motion, right? So they don't have severe contractures. Their glenoid deformity isn't extreme, and I would say deformity more so on subluxation than the wear pattern. I think subluxation is a bad actor. and then obviously they've had other cuff surgery or other cuff disease. I think I have a bias that if someone has cuff tear, a true bone rotator cuff tear on a contralateral shoulder, then I think it's eventually going to happen in this one too. So I think there's some other biases that we sort of lean toward that probably don't have evidence. But if you tease out who the patients that don't do well with an anatomic, then you have a cohort of patients that can do extraordinarily well.
Yeah, those are great, sage words. Obviously, some prognostic factors, the specter of rotator cuff disease, the subluxation. I agree with you. That's really hard to get balanced. What about you, Julie? Any trend lines you've seen in your practice? What percentage are you anatomic versus reverse?
So I thought I was more 30 to 40% anatomic compared to reverses. But actually looking at my numbers recently, I'm probably more 20 to 30% anatomic, which is closer to what the national pendulum has swung to. And I would certainly agree. You have to look at the patient when you're deciding between an anatomic and reverse. Absolutely. There's some patients you look at, whether it's body habitus, whether it's socially, if they're using a walker. There are things that you look at in a patient and you say, you know what, a reverse is going to serve them better, even though they don't have much cuff disease or they don't have much glenoid deformity. You look at the patient and all their factors, and that may be able to swing you one way or another in terms of putting anatomic reverse. So that's changed a little bit for me, just again, looking at patient factors and what I think they'll be able to tolerate afterwards as to why I put an anatomic reverse. I do think, and I would agree with things that have been said earlier, I do think that your best shoulder replacement is still your best anatomic is still your best shoulder replacement, but your average reverse is probably better than your average anatomic, at least for me in my practice.
So I want to follow up with you guys about this because I think that's my understanding also. National trend is that we're pushing towards a place where maybe we're 80% reverse, 20% anatomic, and that it sounds like all three of you have become pickier about your anatomics. You're more and more specific about saying, okay, there's the anatomic person, and there's fewer of those people in your practice than there used to be. So there's, I think, some implications to that. I mean, one of the implications is that, all three of you are relatively high volume surgeons. What does this mean for a lower volume surgeon? I mean, I think a lot of people think an anatomic is a more difficult operation to do, that it's a less forgiving operation than the reverse. I don't know, maybe you would agree or disagree about that. What implications does that have for our training programs where maybe people don't see as many anatomics during their training?
Yeah,
like Mark,
I think
I guess the question I have for you is,
on.
or maybe John, go ahead, run with that. I mean, do you think this creates problems for us, 10 years from now in the way we do anatomics?
So, well, I'll step in front of John. So, and the reason I will is that, so when I do a total or a reverse, it's actually exactly the same operation. The implants are different, but from every other part of the surgery that I do, it's identical, which gives me a little latitude to interoperatively make decisions based upon interoperative factors, as well as what Julia said, that there are preoperative factors, comorbidities, lifestyle issues that might make you push you one way or the other. The other thing that is a little bit, I think, not true. When someone says my best anatomic is better than my best reverse, the problem with that statement is you're automatically selecting people that have less significant mechanical dysfunction to those that have more advanced disease. So it's like, yeah, if I have less disease, I'm going to do better than if I have more severe disease. So I don't really think that comparison, like if you said, okay, I'm going to take people that have 70% subluxation, significant glenoid deformity, and have 90 degrees of active and passive motion, and now I'm going to say my best anatomic will never be as good as my best reverse in that patient, because my best anatomic won't work in that patient, at least historically for me.
Mm-hmm.
So I think that's a little bit, I think ideally there's a spectrum of pathology of intact cuff disease, both from a comorbidity standpoint, plus the mechanical deformities and issues that we have to deal with, that often make the decision-making a little bit more complicated than all or none, at least in my practice. I struggle with this.
So take that a step further then. Flip that patient, right? Take a patient who has reasonably good motion, a
Yeah.
centrally worn glenoid, and right, and let's say the baseline elevation is 140 degrees, and they need an arthroplasty. You're
Yeah.
telling me that a reverse is going to do better than an anatomic in that situation?
No, I agree with you. I think it's sort of
Right.
like saying a less severe disease treated with a more invasive procedure probably is not worth it. And if you just thought a reverse in some ways is a more invasive procedure, not really, but it has,
Not really.
it's not really,
It's
but the
easier.
the concept is that, right? At least that's how I've always conceptualized it. Like straightforward osteoarthritis, balanced shoulder, good mobility, not stiff. Yeah, anatomic shoulder to me isn't the best operation. And to use a reverse is over treating it. Now, sometimes, as Julia said, if they have Parkinson's, or they have to use a quad cane, or they have to use a walker, or they're really obese, and those changes things in my practice.
Right. So
Right.
and I think this is the way we're evolving, right? We're recognizing there are patients, and maybe we're placing judgment on our patients, but those that are expecting higher demand activities are the ones that I'm always thinking I want to do an anatomic if I can at all, even if there's advanced deformity. If this is a super high demand patient, but if you have someone who has reasonable expectations just for pain relief, ADLs, they're not looking for high level functionality, then you can do whatever you want. Do a reverse. It's quicker, it's easier. But, I think that's the way that we're all evolving, right? The problem is if you're only doing 15, 20% anatomic shoulders in your training, like this could go the way of the open bank heart, where the training, we're just not being taught how to do, we're not teaching the new generation of surgeons how to do an anatomic well. And I don't think they're the same operations, even though you're putting in different parts. The way you soft tissue balance an anatomic is different than a reverse. It's different. And to be honest, it's like every different reverse system probably is balanced differently. So there's a lot of variations even in the implant philosophy on reverse shoulder arthroplasty. And that's not what we're talking about tonight. But I do think that balancing an anatomic is an art, and that art can be lost. And I don't think there's like a robot's not going to balance an anatomic shoulder. You're going to have to do it yourself.
Julie, which operation is harder? Is an anatomic harder to get right? Is it more finicky? Is what I said wrong, or do you agree with what I said?
I agree with what you said. The anatomic is definitely, there are a lot of subtleties to it that will make a big difference. Like what you do surgically, that will make a big difference for patients and their clinical outcome. It's a much more finicky procedure, definitely less leeway to make mistakes. It's not quite as forgiving as reverses. So there's a lot more subtleties to an anatomic replacement compared to reverse. So I absolutely agree with what you said.
So then my question is, if you're a low volume surgeon, does that mean that you should just do reverses?
I don't think so. And I think we've talked about a little bit about, your patients and understanding what they need, looking at the comorbidities. And I still think that's you take into consideration what they need. If it's a 52-year-old with an A1 glenoid, I don't think you put a reverse in that person just because you think that's going to be your lower volume. I still think you have to do what's right for the patient. So I think that's important in your training to understand whether it's implant design, whether it's implant selection, all that kind of stuff. I still think it's important to understand what the patients need and how you can best treat them.
So I think a little bit differently. I think that you can use low volume, or people that are technically less efficient would be another way to describe a group of surgeons that may not have the same technical proficiency as other surgeons, either because experience or just whatever. I think a reverse does give them a safety net, because the thing that is most concerning about anatomic totals is glenoid loosening. And with a reverse, with almost every system now, you could be pretty confident that the fixation of your base plate is not going to fail in 99% of the cases, right? So whereas with the anatomic total shoulder, you still have to worry that if you don't get perfect seating, you don't have perfect balance of the shoulder, that the likelihood of that glenoid mechanically loosening in a relatively short period of time is high. So I think for surgeons that are, again, not efficient or productive or volume, I do think there's an advantage, although it's sort of overstating. You still have to do releases. You still have to be facile with the approach. You still have to be aware of intraoperative decisions that are going to impact how you can make sure that the outcome of that patient is best served by the operation you're performing. So it's not a get out of jail free card, but it does provide a little bit of a leeway, as Julia said, for surgeons to not have to be exacting in their procedure to the same extent.
Yeah, it's funny. I mean, we almost know too much. We know the classic pitfalls, an aberrant neck cut, especially done in freehand fashion, overstuffing, potential sizing issues with implants, and then it gets to the soft tissue balancing. Mark, I'm interested. It's almost like you know too much. You've elected to undergo an anatomic total shoulder, right? And
Well, I did.
what do we not know about the path?
When you're asking me, because I have 2 anatomic total shoulders as my
Yeah.
disclosure, is that what you're referring to? But
Yes.
that was not my decision, was my surgeon. And after that, my surgeon dictated what I got. So I didn't tell my surgeon I want an anatomic. I just went to my surgeon and said, I want you to take care of my arthritic shoulder.
Yeah, but if you went to Pat, if you could have selected that person, you could have gone to Pat St. Pierre or Andy Jawa, and you'd walk out with a reverse.
Well, but I had my shoulders well before that was really in vogue, right?
Yeah.
And listen, there was definitely have been times when I wondered if I were to treat myself what I've done, because I don't know. That the thing about the difference in my mind is there's the first 10-year outcome. So if you get an anatomy, you get it perfect. 10 years, it's going to be pretty good. Now, I don't know about 20 years. Whereas if I do a reverse, I think the likelihood, at least radiographically, that those radiographs are going to be pretty unexceptionally changed at 15 or 20 years is pretty high. So, I don't know how to interpret it. We're looking at that now. I have about 100 patients with reverses that have over 10 years of radiographic follow-up, and about 200 anatomics that have over 10 years of radiographic follow-up. And so we haven't looked at that specifically, but my own inclination is the anatomics don't fare as well radiographically. And maybe John's right that the newer generations of implants that we're using now, as opposed to what I did that was a time period from 2005 to 2015. So obviously a lot has changed. So you can make the argument that newer techniques will be better, but that's an assumption. It's a belief, but there's not data to support the belief yet, because by the time that data's out, we won't know.
I want to push you guys on this, because I think what you just said, Mark, is really important. There's now multiple studies that have not been able to demonstrate any difference in patient-reported outcomes between anatomic and reverse. Now, there's maybe some differences in range of motion, but there's no difference in patient-reported outcomes. And there's now multiple studies that suggest that anatomics have a higher revision rate at 10 years. And what you just said about the radiographs is totally true. There's a lot of long-term studies of anatomic that show glenoid loosening is a problem. So if you take both those facts to be true, why would you perform an anatomic arthroplasty? Aren't you dooming that patient to a revision for an outcome that is equivalent? So, John, you said at the beginning you're still doing anatomics. Like, why? Like, how can you look at this data and still do an anatomic?
As a patient I just did today, right? 13 years ago, I did an anatomic shoulder on his other shoulder. He's doing fine. He's got a radiograph that shows superior migration of the humeral head, right, of the anatomic shoulder. He's doing great. He loves his shoulder. He's got a cuff tear, but he's doing great. He now comes in, he's got cuff tear arthroplasty on the other side. I did a reverse on him. Well, I'll see how he does. I think a lot of the failures, the radiographic and even cuff failures, that we are so adamantly concerned, that so worried about, that we will just switch the implant and do a reverse. I think some of them, they actually fail surprisingly quietly. And I think if you just did it based on radiographic standards, then yes, because of glenoid loosening, maybe poor polyethylene or a combination of both, not even 3 generations, the last generation of implants we used wasn't that good compared to what we have today. And I think it's like you're throwing the baby out with the bathwater before you even know if an innovation has really made a difference. I mean, there's some 10-year data now, I think, on hybrid glenoids that was pretty damn good, right? That data is way better than the all polyethylene glenoids that were studied for years, that are giving these really poor results in radiographic loosening and failures at a high rate of 10 years. Like that 10-year data that you're referring to is with bad implants. So I'm not ready to throw that out. I believe, I look at 5 to 7 year data X-rays on vitamin E polyethylene with enhanced fixation glenoids, and I'm not seeing that same glenoid loosening. I'm not.
So John, the 10-year X-ray comparative study is the same time period with reverse implants that theoretically were not near as advanced as our current offering, right? So I buy that we are much better in anatomic arthroplasty. At least I believe that I am, although I can't prove it with any data, but I do it based upon a belief that anatomical reconstruction, restoring joint line, getting version back to premorbid anatomy, respecting the head diameter so you don't oversize or overstuff. I believe that I am much better because I didn't know about that. Like in 2015, that didn't even exist. That concept, that understanding didn't exist. Now, I still manage occasionally to probably get that right, but the reverses were probably not as, they were all cemented. They probably weren't, I wasn't as facile doing them. So you can make the argument that both have advanced.
I mean,
I think both have advanced, but I think our techniques and our understanding, like you said, Mark, our techniques and our understanding of anatomical reconstruction of how to do these shoulder arthroplasties, that's also changed. So I would like to think that surgeons, we do a better technical job now too at understanding not overstuffing. You don't want to put the rotator cuff at risk. You want to make sure your glenoid, you want to see the interior border, you want to make sure you're putting in the right position. So I think we as surgeons, also our techniques have also advanced, so that may also change the long-term results of anatomic versus reverses.
Yeah,
one other thing that we haven't
believe
talked
that.
about, we haven't talked about one thing that I think is important, and I used to refer to it as the complication severity score. And if you look at early failures and early complications that you see, and you compare anatomics to reverses, I mean, what's the worst thing that happened? Take out infection or nerve issue, right? But what are the things you worry about the most with the anatomic, like a subscat failure? And I can show you 5 and 10-year data on patients who have subscat failures that are just doing fine with their anatomic, right? Compare that to what we see with a reverse, where you get an acromion fracture, which could be a dramatic impact on function.
But
you have
that's
this
rare.
anterior shoulder pain that we can't explain in probably a good percentage of patients that nobody talks about. So that could be severely debilitating for patients. So yeah, we're looking at 10-year outcomes, but even in the first 6 months, right, the risk of having reverse-related issues is a higher level of impact on patients if something goes wrong.
Yeah, I disagree.
That's so funny, John. It's so funny. I read your paper on the results of anatomic with subscat failure, and that's not my memory of the results. My memory of the results is that they're worse.
They're worse than they could have been. They're worse than if you compare it. Yes, but this is 5 and 10-year data. The concern with the subscat failure is that you are going to fail dramatically, which is not the case. They have a higher rate of glenoid loosening, but they're functioning high and they exceed MCID scores. That was the
that's in the group, right? There's some cuff failure that have dramatic pseudoparalysis that require early revision, right? So that's
a low percentage.
Yeah, but it's a low percentage of a acromial fracture that is significant in osteoarthritic too. I mean, I think that for me, the real value in an anatomic arthroplasty is if you can restore joint line, get back to premorbid anatomy, you potentially can restore the kinematics of the shoulder closer to a normal shoulder. And if I believe, which I do, that the normal shoulder kinematics are designed in order to maximize function and reduce wear because they're balanced so well that the force distribution is perfectly balanced, then, and I think that leads to other things that we can't measure, such as compensatory scapulothoracic motion in a reverse that you might not see in a perfect kinematic reconstruction anatomic. That might have implications of progressive degenerative spine disease, for example. So if you look at your osteoarthritis, it's very common. You see concurrent spine disease. And you might think it's because they have a systemic osteoarthritis, maybe, but it might be that they're compensatory, trying to raise the arm by flexing and extension their spine. So to me, there are some benefits to answer why we would do anatomics, even though all the data would suggest what I said, is because there are these things that we can't measure that we believe to be, or at least I believe to be true. I can't prove it yet, but I believe that that's probably what happens, and why I think look is if we get technically able to have technology to make an anatomic shoulder arthroplasty, that we can do it every time, reconstruct joint line, version inclination, have implants, have perfect wear characteristics, and great fixation. This won't be a discussion anymore because
So
everyone
let's
will want to do, you know.
I love it. Bold prognostications from Dr. Frankle. I wonder if we can recenter the conversation on some of the new school discussion that may usher in a whole new generation of anatomic principles, and that's that of the alternative bearing surface. You know, pyrocarbon. Are we going to see a swing back of the pendulum towards more of these anatomic principles? Julia, where do you see us going?
I think as we, excuse me, as we have a better understanding of reconstruction of anatomic principle, we talked about restoring the joint line. We talked about like rotator cuff kinematics and scapulothoracic kinematics. As we have a better understanding of how that plays into shoulder replacements, I do think that alternative bearing options, I think, give us, you know, it becomes a much bigger, or it's a good potential option, because now we talked about the glenoid wear. Maybe we have the metal on the glenoid side and the poly on the humeral head side. Hey, maybe that's going to eliminate the glenoid wear component. So in Europe, they have some components that are designed in that way. I do think that having something that changes the wear pattern or changes our ability to fixate these implants, that may give us a whole new lease on what we can do with shoulder replacements.
What about you, John? You're an ardent believer in anatomic arthroplasty. You've been advocating for it. Do you see a role here? And maybe if I can add one additional question, should we be worried about the potential untreated arthritis on the glenoid side, or is this just a different animal?
So I think that there's always probably been a role for a hemiarthroplasty. I've historically done it in my very young patients where I worry about the second operation 20 years later. But I think, you know, if we follow in the lead of the hip arthroplasty surgeons, I imagine ceramic on vitamin E poly will be the go-to the alternative bearing surface. It's just not available in the United States right now. But it's very promising because it has a very allows you to do both, right? It allows you to resurface both joints, both halves of the joints, and probably do it in the kindest way on the wear characteristics. But I think that right now, the most important emphasis is what Dr. Frankle alluded to earlier, is the anatomical reconstructions. And if you could do an anatomical reconstruction with a hemiarthroplasty and a well-centered glenoid, there's probably some really good, strong evidence that you're gonna have a good result if you balance it right and you have the anatomical reconstruction. If you overstuff that same shoulder, you're gonna get glenoid wear. Period. Whether it's a pyrolytic carbon head or a metal head, it doesn't matter. If you don't get the anatomical reconstructions right, that's what you're gonna see. So, you know, the resurgence of this appreciation of understanding what is a real anatomic reconstruction, that's critical. So the alternative bearing surfaces are really interesting to me. I think it's still very early, but remember, we're behind the times in arthroplasty compared to the hip and knee, and I think we'll probably follow suit in their direction.
Yeah, Dr. Frankel. So, we follow the data registries from, say, Australia very closely. And obviously, there's a little bit of divergent thinking. On one hand, it's going towards hemiarthroplasty. They think that this will solve all. They'll be self-centering. There'll be less erosive wear. And then there's other folks that adhere more to this anatomical reverse, and that's the new school. Where do you fall out in this
Wow.
discussion?
So I'm not. It's funny, John said that. So when I was trying to make my decision of having surgery, I was at this. Dr. Cofield was my surgeon, and hopefully that's not violating any rights. But the day before my surgery, we were in conference, and the discussion is like, Dr. Cofield, who would you do a hemiarthroplasty? And so it's the standard now, young, active, blah blah blah. And so I fit that criteria. I was in my 40s and I was an avid weightlifter, orthopedic surgeon, and I'm like, there's no way. And then he added the last caveat, someone who's stoic, which if you know Bob, that meant like, you're really, and that's one of the issues. Like if you take a really bad osteoarthritic shoulder, almost any operation you do will improve their life. And they don't have a comparative operation to see if you did a total, it would be better, or a reverse, or a pyrocarbon hemi. They just know that they're better than they were. And that's because, in general, osteoarthritic shoulders, if treated surgically appropriately, probably have a good outcome. But clearly, when you look at large data sets, as opposed to 95 out of 100 people being satisfied, it starts to go down because of the predictability becomes more difficult. So I'm skeptical of materials solving mechanical issues in themselves, and not sort of applying what John said, the idea that we want to try to recreate some normal anatomy structures to recreate kinematics that would be favorable for a durable outcome. I don't think that the materials can make that big of a difference, but I might be wrong.
I want to, you mentioned the activity profile that, at the time you were a weightlifter. And one of the things that I wanted to ask you guys about are there specific patient activity profiles that are bad actors with the reverse? Like, for instance, like where I practice, I have some patients that are coal miners, and I've learned the hard way that if you're a coal miner who has to be a Rolf bolter, you shouldn't have a reverse because it's too much. It's just too much on that arthroplasty. So I have the same question for you guys. I mean, is it swimmers? Is it tennis players? Like, what are the patient activity profiles? Is the people that have to chop wood to heat their home in the winter? Who are the patient profiles where you say this patient really should not have a reverse? John, what do you think?
I used to think tennis players who are really competitive tennis players at high level. Then we did a study that showed there was no difference. So I don't think that I'm teasing out a difference at all anymore. I have had a single patient, heavy weightlifter, who presented, probably way too long after he had dissociated poly and had metallosis like I've never seen before. And I can't help but blame something on that. I don't know if that's true or not, but that's in my head. But that's one. And I have plenty of guys that are back in the gym, and we participate in the multi-center study for weight training. We actually have our own manuscript that we just submitted on weightlifting. And patients get back to weightlifting if they want to weightlift, whether they have an anatomical or reverse. So I don't have issue with that, and I haven't seen a whole host of failure. I've had one, which you're only as good as the one that complication that haunts you in your head. But I've had way more patients going back to weight training without any limitations. So I don't put limitations. They're going to do what they want anyways. Frankle taught me that a long time ago. I watched him do it himself. So I don't think you can put true limitations. I don't think you got burned by a specific example of a coal miner. I don't see that kind of stuff. I see people are retiring and try to play golf and swimming and tennis and all that stuff, and I don't hesitate at all.
What about you, Julia? In your part of the country, are there specific activity profiles you think are not compatible with the reverse?
I don't think so. I do think, I have a lot of mechanics that are in my practice as well who are underneath cars. They need to get their arms in like tight little spaces to be able to fix engines. Those patients, I do let them know, like, hey, if you're going to have a reverse, your mechanics are going to be different. So the way that you do things, that you've always done things, may be a little bit different. Those patients have a little bit of a harder time. When they're laying back on the ground, their scapulothoracic compensation is a little bit less in a reverse just because their scapula is against the ground. So I do tell those patients, at least in advance, that they may have some difficulty or they may need to change the way they do things because their shoulder mechanics are going to be a little bit different with the reverse compared to the anatomic. But that doesn't necessarily change what I do. It's something that you do counsel your patients on, but I don't have a patient profile that would swing, at least for me right now, one way or another.
Mark, share your thoughts.
Yeah, I don't, that doesn't enter into my decision at all. I have, a lot of very active. I have this one, Mr. Universe, who has bilateral reverses, and you wouldn't be able to tell. Yeah, if you watched him work out, you wouldn't be able to tell. If you looked at his motion, you wouldn't be able to tell. And so I wonder, that guy's like 9 years out. So I in my mind, my mental exercise is, if I did anatomics, would his x-rays look like his x-rays are undistinguishable from his first post-op visit? But I think if I did totals on him, now he was really asymmetrically worn, and I wanted to do an anatomic. I couldn't. He was too asymmetric, too medialized. I couldn't establish joint line. I couldn't get adequate fixation. So intraoperatively, I'm doing a reverse. And then he loved that side, so I did his other side about 8 years ago. So I wonder, if I did an anatomic, if his radiographs would look the same 8 years later. And I don't know. I'm sort of suspicious that they won't, but maybe they would.
Dr. Frankle, just to follow up on that, are you saying you have no restrictions on your reverse patients postoperatively?
Well, I don't tell them, because I don't think even if I told them it would make a difference. So, I mean, you can tell people not to do things, but if they feel they can, they will. Now, if you tell them not to do things and then you ask them if they're doing those things, they'll never tell you they're doing them. So if you really want to get an idea of what your patients are doing, you just have to say, look, I'm going to trust that you are going to take good care of this operation that we did, because we're partners in this, and you're going to use your judgment. And, sometimes they don't. And sometimes you only retrospectively realize that your patient selection was flawed. Like, how often do you realize after you operate on someone, you didn't really quite understand that this patient was an alcoholic, for example, because you asked them about their drinking history and they said they drank 1 or 2 a week or something. And you realize it was 1 or 2 bottles of vodka they were talking about, retrospectively, when they would go into DTs. So, I mean, sometimes, we get burned because we didn't quite understand who we are taking care of. So I don't put restrictions on anyone, period.
And Julia, John, do you put any restrictions, just to lay this out there?
I give them guidelines. I don't give them full restrictions. Sometimes if it's a workers' comp thing, it'll be a little bit different. But I do think that, you give patients guidelines. And like Dr. Frankle said, if they want to do it, they're going to do it. So you kind of explain to them, same thing, that I want you to be a good steward to the implant. I want you, it's a wear thing, it's about repetitions, it's about the shear stresses that your implant sees. So the better care you take of it, the longer it's going to last you.
Yeah, I approach it similarly. I do tell patients there's a difference between what you have the capacity to do and what you should do. Because I think you'll have the capacity, if you have a great result, we'll high five each other, and then you have the ability to do literally anything you want in life. But you have to be smart about it, and life's about risk and risk reward. Know that when you put excess load of any kind at some level, you're putting additional strain. But we have zero evidence that says that there is a X number of pound limit on what a joint replacement can withstand. We don't know that. It's all speculation, and it's all our gut and our guess. But it just makes common sense that if you load it heavily over time, you're going to create wear, period. Be smart about it. That's all.
So
And I give people the leeway to do whatever they want.
So I flip this a little bit because the biggest problem that we have in looking at our quality, which turns out to be our research, is follow-up. So I say to the patient, look, you can do whatever you want. The only thing I ask of you is to follow up regularly so we can look at your radiographs and assess whether or not your lifestyle is impacting your wear or your implant. And if you come in every year, and then it's probably we'll have a much better idea in a prospective fashion to give you feedback about is your lifestyle potentially going to impact the durability of your arthroplasty. Now, I don't know if that helps, but it helps me try to get them to follow up so I can have better long-term data, which I think is overall going to provide better evidence about what we're talking about.
So along a real interesting comment here. So along the same lines, right? I ask for patients to come in annually as well. We just looked at our population of weight lifters, right? Patients who wrote on their follow-up that they are weight trainers on the ASES score. What sport do you do? And of the patients who said they were weightlifters, I had 92% patient follow-up at 66 months. Like these patients are doing stuff, right? They're working out and they're probably worried about it. So they're definitely coming in for their follow-up to make sure that they're doing okay and they're not. They're testing the limits, but they're worried. So they continue to come in for follow-up. Real interesting commentary on that.
Yeah, I mean those are great comments. You know, we've really dug into this whole concept of the rotator cuff and the natural history, and we've learned a lot from talking to the likes of Jay Keener and Stefan Moosmeyer, and we know that this rotator cuff disease is progressive. I wonder how you take this into account as you deliberate this anatomic versus reverse decision. And specifically, I kind of want to know what's your upper limit on structural or radiographic changes where you say, if it's above this, I'm no longer entertaining an anatomic. John, can we start with you?
Are you specifically talking about cuff disease? Like, what do I do to figure out if the cuff is good enough for its anatomic?
Yeah, they come in with an MRI or structural changes you see at the time of surgery. Anything that you use to delineate an intact cuff, but looks like it's at risk for more progressive disease. You alluded to it in some of your earlier discussion, but I really wanted to dig in for our audience.
Yeah, I still believe that I kind of almost have always separated osteoarthritis and cuff disease as almost two separate pathways. Now, obviously, the Venn diagram intersects, and there are patients who have severe arthritis that you look at an X-ray and you'd never think it, and then you get into the shoulder and there's a big cuff tear. It happens probably more frequently than we want to admit. So I don't get MRIs on patients unless if they don't bring an MRI with them ahead of time. I usually don't know. I'll look at a CT scan and I'll look for atrophy of the cuff. I'll look for any signs of bursitis and you can see in the soft tissue windows a lot of times if there's a cuff tear. So I'm looking at that. But if they don't have a full thickness cuff tear and I'm planning for every other reason to do an anatomic, I'm doing an anatomic. If they have a full thickness cuff tear, then, have I done a cuff repair at the same time? Absolutely. If it's a literally crescent shaped 1 centimeter tear, but not ones that are much bigger than that. But there are that probably, I'd say the number of times I shift intraoperatively from an anatomic to reverse because it was a cuff tear, I would say it's less than 5%.
Julia, one step further, prior history of rotator cuff repair, radiographic arthritis. How are you evaluating this patient to determine their candidacy for a rotator cuff or for an anatomic shoulder arthroplasty?
I think that's a great question. It depends on the size of their previous rotator cuff repair. If it was a small 1 anchor repair, or if it was, a double row 4 anchor, 5 anchor repair. I also look at their clinical function preoperatively. You can test. There's obviously some pain associated with their osteoarthritic changes, but I would want to make sure they have a forward elevation more than 120 degrees. I want to make sure that they have relatively good strength with their cuff. So I do think that clinical picture matters there. There are ones that you may be able to get an MRI on those, especially if they're younger patients that are undergoing surgery. Those are patients I would probably get an MRI on just to double check. But this is when we talked about earlier, you look at your patient. patient with a prior, large rotator cuff repair, 65 years old. These are patients I'm going to put a reverse in, just because you don't want to have a cuff failure later on if you know that you can have a little bit more security or a little bit more leeway with a reverse replacement. So again, clinical picture matters with these. My threshold for getting an MRI in those patients, if I'm considering anatomic, is a little bit lower as well.
One of the things that I think is interesting is that, this is changing, like as has been mentioned, the data from 10 years ago, those were different implants, but the future also holds different implants. And as mentioned, we're getting better at the anatomic and we're getting better at the reverse. Mark, certainly you've driven us so far forward with the reverse. I mean, such an important piece about our innovation in the reverse, over the past 20 years. I think the question I have for you, Mark, is, are we going to get good enough at the reverse that it will be just as good as the anatomic, and then maybe there will be no reason to do an anatomic? Like, is that one of the potential futures here?
Well, it's one of the potentials. I think one of the, what drives innovation is it really varies. So my reason for innovating is because I looked at my outcomes and I saw that certain subgroups of patients that I treated did poorly, and I wanted to change that. So I then felt that there was a really good role. The problem that we're facing is our outcomes are exceptionally good in both of those. And then the question becomes, how much better are we going to become with investment into that, like trying to make it better? So I do think, there's not been a great deal of thought of modifying our reverse implants for intact cuff patients, right? So, I and Adi would ask each of us to say, do you do the same operation for an intact cuff as you do for a cuff to arthropathy when you do a reverse? And if the answer is yes, then maybe there is some room to modify the procedures based upon the pathology to optimize function. And then if you thought that way, then you might think, well, maybe we can even improve the implants for those pathologies that we're currently treating with. So it just depends, because now innovation is market driven as opposed to maybe problem driven. So that changes the little trajectory of how things will innovate. But there's always that unforeseen innovation that changes everything.
I think those are great words to land on. You all have offered incredible food for thought. I really loved the discussion and the repartee. I think we have more than enough for an hour and a half of content, but I want to be respectful of your time. Peter and I thank you for being our guests. That's about all the time we have for this podcast. We really want to thank you all three of you, such experts in the field. And for all our shoulder elbow listeners out there, don't forget to subscribe, and we'll see you next time. Thank you.